Thank you all for joining us. And we are delighted to do the podcast on diabetes as a part of our Brown Heart podcast series. So, our goal is to talk about top 10 things you need to know in 2025 about diabetes. So, the first we talk about question number one, everybody needs to know what is diabetes. So, a normal fasting sugar after 8 hours of fasting is 100 or below. Anything between 100 to 126 is known as pre-diabetes, and anything above 126 is called diabetes. So, remember the fasting of 8 hours. However, you can also do a non fasting test, which is called A1C. This measures glucose for the past 3 months, and less than 5.7 is normal. More than 6.5 is diabetes, and between 5.7 to 6.4 is pre-diabetes. A lot of the people who are joining me today probably know all this, so I'm going to go through some of these slides quickly so we can focus on important things. So let's talk a little bit about type of diabetes. So when we think about diabetes, there are two types. One is type 1, which is your body is not making insulin at all. This is called the insulin dependent diabetes, which happens in kids and young population. And this is really less than 10%, where you have to be dependent on insulin all life. But type 2 diabetes is where we are going to focus most of the time today, where body makes insulin, but it's not able to use it properly. So what happens, as you can see from the picture, the pancreas makes insulin. So in type 2, you're making insulin, but because of insulin resistance, you're not able to use it. This is called the adult onset diabetes, and it is 90% of the population. So let's look at the trends. This is the most important question for today. What are the trends of diabetes in South Asians? So we have seen increasing trends in all countries for all diasporas, whether it's India, US, UK, Australia, or any other countries. And the prevalence of diabetes has gone from 11.2% to 22% in many studies. We remain higher than all Europeans and all US population. Close to 10% is the normal diabetes prevalence. And you can imagine South Asians have the prevalence of close to 20%. The other most important point is all South Asians get diabetes 10 years younger and a much lower body weight than the other populations. So that leads to the question, why? So why do we get diabetes early? And the concept is thin fat Indian. We talk a lot about this in Brown Heart, so I'm not going to spend a lot of time on this, but basically we are thin from head till the above the navel or just waistline, and then below that we get most of our fat collection in our abdominal area. So this is called a thin fat Indian. So for the same reason, we have a lower BMI, but we have much high visceral fat. When you deposit fat around the abdominal area, you don't just deposit in the subcutaneous tissue, you also deposit inside, which is around the organs, liver, muscles, heart. And that is why we are called apple-shaped and not pear-shaped. The pear-shaped means when your fat is collecting around the buttock area. But apple-shaped is when your fat is collecting around the abdominal area. And a very important thing is we have less muscle mass. We are grown thin, but we also have less muscles and more fat. And why is that important? In muscle is where the glucose is first utilized and then utilized as an energy source. So if you don't have enough muscle, the glucose utilization remains poor. So a talk about BMI, it's very simple. You know that BMI is weight in kilograms divided by height in meters square. So the normal BMI for Americans is 25 or less, but for Indians, it's less than 23. And for us, 23 to 27 is overweight and more than 27 is obese. So we are much more heavier at a much less BMI, again talking about the thin fat Indian. So these are important calculators for you. And again, these slides will be shared with you as PDF, so you don't have to write anything. The ADA gives you many different calculators for calculations of these. There's a 60-second risk test for type 2 diabetes by ADA. Calculate your BMI, and diabetes-related retinopathy risk test from the American Diabetes Association. You can go on their website and you can find this. So question number 4. How do you know you have diabetes? So majority of the time, there are no symptoms. Especially the pre-diabetes, which is a step before diabetes, is completely asymptomatic. And you can have increased thirst, increased hunger, tiredness, blurred vision, increased urination, and weight loss. But all of them come very late. Most of these symptoms don't even start till your sugar goes above 250 to 300, because that's when you start to pour glucose into the urine, giving you the symptoms. Type 1 diabetes, completely different. They will present with these symptoms right away. But in type 2, you will not get any symptoms. So 80 to 90% of the time, you'll only find out by testing. So what testing do we do? Who should get tested? Very different for South Asian than American Diabetes Association guidelines for Americans. Any South Asian above 35 years should be tested for diabetes. And if it is normal, which means the fasting test like I talked about, it should be tested every 2 to 3 years. And in fact, I would suggest getting a test every year would not hurt. But this is the caveat. If you have any of these, you should be tested earlier, even in teenage or above age 18. So if you have one of these more risk factors, like you have a low HDL of less than 35, which many South Asians have, if you have high triglycerides above 200, again, very common with South Asians, if you have a first degree relative with diabetes, if you have a family history of heart disease in male less than 50 years of age, if you're obese, BMI of more than 23, either overweight or obese, if you have history of high blood pressure, if you have history of gestational diabetes, and if you have borderline diabetes or pre-diabetes, you need to get tested every year and should be tested above 18 years of age. So once again, important that every 18 years or above should be tested if you have any risk factors. So let's lead to a question 5. Once you know now that you have diabetes or pre-diabetes, what does diabetes do to you? Why are we worried about it so much? So I call it a silent but nasty disease. And my cardiologists call it diabetes is equivalent to heart disease. So anybody who has diabetes, we think about them as they had heart disease. But in between, diabetes affects your eyes. It can cause blindness. It can affect your nerves, and it can cause feet problems, eventually ulcers, and even amputations. It affects kidneys and can cause kidney failure. And obviously, it is the number one cause of heart attack and stroke, especially in South Asian population. So once you have diabetes, and this is what's happening with diabetes, is there a way you can prevent these complications? And you can. So how do you take care of yourself if you have developed diabetes? You need certain tests. A hemoglobin A1C every 3 months, which gives you an average blood sugar reading. A normal value, again, I told you, is less than 5.7. And we'll talk about the goals for diabetics in a second. Cholesterol panel should include LDL, HDL, triglycerides for all South Asians, and it should also include LP(a). Urine test specific for a protein called as microalbumin creatinine ratio, which is a special test. A normal urine exam will not test for that. So if your doctor has not done it, please ask them to do it. And it should be done once every year to find out the early stage of kidney disease. An EKG as a baseline, and of course, liver and kidney test every year. And one thing I forgot to mention, an eye examination test every year. You need to go see an eye doctor once you have become a diabetic every single year. So what are the goals for diabetes? Let's say if you have become diabetic, again, the American Diabetes Association reflects the goals here, but the goals are very different for different people. So we really favor a very stringent control of less than 6.5 if your diabetes duration is short, if you're young, if you have no problems with low blood sugar, and if you have other issues but no cardiovascular complications. So the younger you are, the stringent control means less than 6.5. And then as you get older, we try to talk about most adults keeping at least less than 7. And healthy older means above 75. We try to keep it less than 7.5. And you can go on. If you have much more comorbid conditions, like you get a low blood sugar, or if you have severe heart disease and other medical conditions, then we really truly like to keep you either less than 8. Definitely at all time, we like to keep it less than 9. And the reason is for anyone who has an A1C above 9, you have a higher chance of getting hospitalized with high sugar and complications. And anything with an A1C above 9 is really called poor control of diabetes. So what are the other goals for diabetes you want to keep? Your LDL, like I told you, less than 100 in all, but less than 70 if you have diabetes, because it is equivalent to cardiovascular risk. HDL, more than 40 in males, more than 50 in females. Triglycerides, less than 150, and the blood pressure 130 over 85. And by chance, if you have urine microalbumin positive, like if you have an early part of protein positive in your kidneys, your blood pressure should be even lower, 125, 75, 120, 70. The lowest you can keep is better for your kidneys. So that leads to question 7. Are monitoring devices good for me? And a lot of diabetics ask me this question, even pre-diabetics. So currently, there are 2 monitoring devices out. There's another one out on Amazon as well, which is not FDA approved, but it is also available. But the 2 which we use more commonly are the Dexcom and the FreeStyle. So Dexcom, what they do is they actually measure your sugar every minute and give you readings like you can see on the graph. And I'm going to talk to you about that in a second. FreeStyle you can use for 14 days and Dexcom you can use for 10 days. These are sensor-based systems. So you actually put a little quarter type sensor on your arm or on your belly, and it provides you a real-time glucose readings day and night without any need for finger sticks. We used to have to calibrate them, but not anymore. So these are great devices, but unfortunately here, insurance company only covers them for people who have been on insulin or are on insulin therapy, or if you have severe hypoglycemia or low blood sugar, that's when they give you these devices. But the good part is that, like I have said here, Dexcom and FreeStyle both have a free trial program where they give you one sensor for free. So anybody can go on these websites and put in your information, and they give you a coupon which you can put it on for free. Why is it important? This is how the data analysis looks like on the CGM. And I hope you can see this slide well. But on the top left column, you see there are 3 colors. The green one is how much your sugar is in the goal, which is 70 to 180. Yellow is how many times your glucose goes above 180. And then, of course, more than 240 is severely high. It also tells you how many times you're hypoglycemic and the severe one or the mild one. So you can see these numbers and tell you how good your control is. And ideally speaking, for diabetes, you need to be in the green range at least 80 to 90% of the time. And then it also gives you graphs, which you can actually get it on your cell phone, pretty easy to see. And you can see that the column, the goal range is green. You can see that this person, after eating meals, clearly goes high into the orange range, which means his glucose is really touching close to 300 after he eat meals. So this really has been a game changer for people by wearing these devices for 10 to 14 days. You can see in the lower column, there's a daily graph it shows you. So I can clearly look at this device in 1 second and tell you that the problem is food, because every time you eat food, your sugar goes up high. Otherwise, your glucose is within the very normal range. So, do I suggest this for pre-diabetes and diabetes to put it on if you're not on insulin? Absolutely. I think if you want to put it on for 14 days as a free sensor, it'll give you some guidelines as to what food increases your sugar. And it worked very well for me because I always thought, the corn and saag, makka ki roti and saag was my favorite. And it should not, because corn is complex carb and I'm eating a lot of greens with it. So it should not raise my blood sugar. And actually, it raised my glucose to 220 when the wheat roti does not do anything. So I think this was an eye opener for me, and it immediately changed my philosophy. And I started to add either jowar flour or wheat flour to my corn flour so I can make it healthier. So I think this is how it changes behaviors. So if you want to use it, it's clearly non invasive and doesn't hurt. For diabetics, there is also another one which is approved called as Eversense, and that you can actually place inside the subcutaneous tissue. It is done by the doctors and it stays there for 6 months. So you don't have to keep changing it. So there's a lot of good data now coming out on Eversense, and we can talk about it more in the question if somebody has any. So now get to the meat of the problem as to how do you prevent diabetes. Simple things: diet and exercise. Maintain your BMI 23 or below. You can use drugs which can be used to prevent transition from pre-diabetes to frank diabetes. And you can use metformin, which actually reduces the risk of diabetes from pre-diabetes. So there is very clear data from diabetes prevention trial that if you had pre-diabetes and you had an A1C above 6 and you used metformin, there was a 30% more improvement in chances of improving prediabetes, so you don't become a diabetic. So diet and exercise improves your risk of developing diabetes by 60%. So which means if you eat healthy diet and exercise, there's a 60% chance you will not become a diabetic, even if you're pre-diabetic. But if you add metformin, then there's a 90% chance that you will not become a diabetic. And there are also newer drugs like GLP-1s. And these are available to both prevent and treat diabetes. And I am going to focus a lot on them in the future slides. Okay. Something is not. Sorry. Okay. So let's focus a little bit on diet. And again, I'm not going to spend too much time because we have done a full podcast on Indian diets and we'll be happy to send the links again. But for diabetics especially, I'm going to focus more on diabetes related. So diet is our biggest weakness as South Asians. And I think if you have to pick two things, it's the rice and the sweets. We just cannot give up rice and we cannot give up sweets. Rice for us is not a side dish. If you go to eat American food, rice is a side dish. For us, it is the dish. And just one more mithai is how it all begins. I'm just having one sweet. I'm not going to do anything. Healthy snacks. Oh, I baked samosas instead of fried samosas. But it still had the same amount of carb and it had the potatoes and the fried maida. So it didn't help your sugar. We have a very high salt fried namkeen, both fat and carbohydrates. And of course, we can give up our sugar in the chai. So there are 3 or 4 things I want to focus on diabetes. Just to remember, 1 gram of protein gives you 4 calories, 1 gram of carb gives you 4 calories, and 1 gram of fat gives you 9 calories. So from the weight standpoint, if you want to cut out the fat more than the carb and the protein, you're going to lose more fat quickly and you're going to lose more weight quickly, especially giving up fried stuff. However, for diabetes, you really need to focus on your carbs. So why count carbs? Because 55 to 65% of your calories come from carbs. Carb is a quick source of increasing sugar. And for us, for day-to-day function, our brain functions only on glucose. So carb is a very quick source of increasing sugar. So that's why we need carbs in our diet. But there are really 2 types of carbs. One is simple or refined carb. that causes a quick increase in sugar, like juices, sweets. The two big ones, like maida, like white rice. These are simple carbs. And when you eat them, the glucose starts to really go up within 15 to 30 minutes. Then there are complex carbs, and these carbs take more time to digest. And these are your pastas and potatoes, sweet potatoes. And with pasta, like if you do a wheat pasta, it becomes even more complex and it takes longer time to digest. And the third principle to remember is one carb is equal to 15 grams of carb. These are just for the principle of simplicity, I'm telling you, because I'm going to come to that in the next slide. Okay, so if you look at your calories, and we have talked about how do you calculate your calories with TDEE, I'm not going to focus on that. But roughly speaking, most of the average female should be close to 1500 calories, and most of the males should be close to 1800 calories. Now, again, it depends upon your height and weight. So if you're eating that kind of calories, if you think about your breakfast should consist between 3 to 4 carbs. And what that means is one carb is 15 grams, so a total of 45 grams of carb in the morning and total of 60 grams of carb for an 1800 calorie. And you can see the rest of the day. So a total amount of carb for 1500 calorie person should be roughly around 160 to 180 and a little higher for 1800 calories. So now I'm going to give you examples of the carbs which after I talk to you about the food label, I want to talk about the food label first. And I just want to focus on the carbohydrate. How do you find out how many carbs a food has? So start looking at the food label. And while looking at the serving information, so serving size is most important. So let's say this has 1.5 cup is your serving size. When you look at the carbohydrate, which is below, it says total carbohydrate is 40 gram, which is 15% of your daily calorie based on 2000 calorie diet, which means it's probably more for us. Now, also equally important is to look at dietary fiber, because when you have fiber, the more the fiber, the better your carb is, because again, it decreases the digestion of the carbohydrate and your glucose does not go high as quickly. And the third important thing to look at is added sugars. When you see anything like added sugar, which is 16% in this label, that has a lot of sugar, which is not good for your diabetes. So important thing is, even though the carbohydrate are 40 gram, number one, it is pretty high in this compound. There's less dietary fiber and more added sugars. You want to see the switch. You want to see the dietary fiber 5% or more to make it a complex carb. Okay, so these are just some of the examples which we have shared before, just to give you that how much rice you can quickly get, how much carbs you can quickly get. So 1 cup of cooked white rice gives you 45 grams. A jalebi gives you 30 grams of carb. A cup of quinoa gives you 40 grams of carb. But when you look at quinoa, it also has protein and fiber, so it actually makes it a complex carb. One naan has 45 grams of carb. Simple Coke, regular Coke, has 40 grams of carb, and that's all simple sugar. So you get the drift. You can look at these carbohydrates on a daily basis. And from the previous slide, what I told you, divide them into 3 or 4 different parts when you eat your food. And make sure that your carb content remains the same on a daily basis to prevent the sugars from going up and down. So in our podcast, we already have given you the carb content of every food, Indian, South Asian food. But Dr. Wagle also has a carbohydrate counting book for South Asians. So you can also buy that on Amazon and look at that. And just before we move away from the diet, I just have a word on artificial sweeteners, because this question comes up with, especially for diabetes patients all the time. So yes, the sugar has a lot more calories. Honey, brown sugar, all of them have equal calories, and artificial sweeteners have none. So there have been 2 concerns raised for artificial sweeteners. One is the cancer, which clearly has not been panned out in the practical amounts we take, like up to 5 packets a day or 6 packets a day. There's no increased risk of cancer. However, there's a lot of data coming out now that even in practical amounts, when you take 2 to 3 packets a day, there is a slight increased risk of diabetes, coronary heart disease, and stroke from sweeteners. So, yes, the ideal is in your tea, no sugar. But if you can survive without it, the artificial sweeteners, which are healthier, are natural sweeteners, which is stevia and allulose, truvia. These so far have absolutely no data on increasing diabetes, heart disease, or stroke. So you can clearly use the natural artificial sweeteners as compared to sugar. And then, before we move on to the treatment part of diabetes or prevention or diabetes with drugs, I think this is probably the most common asked question to me about diabetes. How do I prevent diabetes? Can I take plants and herbs? And in fact, one of the questions just came before the talk was jackfruit. And I did not include jackfruit in this, but jackfruit has the similar data like this. So what we did is I did a lot of research on all the plants and herbs. And actually, there is good data out there on all of them in early stage of diabetes or pre-diabetes. So if your A1C goes from 5.7 to 5.96, or even if you just become a diabetic at 6.5, there is no harm in using herbs or plants for improving diabetes. And these 7 or 8, they're total of 80 Indian medicinal plants, which are used to control or prevent diabetes in Ayurveda. And there's a lot of data on them. 2 or 3 important points. Number one, the studies are very small, somewhere between 25 patients to 300 patients to a max of 1,000 patients, which is a good study. And the studies have only been done for 3 to 6 months. So we don't know if the long-term studies are being done, which are currently in progress, but we do not have data. So I picked 8 out of the 80, which had good data. So you can look at cinnamon bark, apple cider vinegar, aloe vera, berberine, which is a supplement, karela, fenugreek seeds or methi seeds, and black cumin seeds. And as I said, there are multiple more. And by the way, jackfruit comes in the same category. The couple of things to important things to recognize is how much you have to drink or eat every day for them to get the benefit. So in different study for cinnamon, there was 100 to 6,000 milligram of cinnamon used every day, like apple cider vinegar. And actually, I tried it yesterday myself just to see. I could not drink the water even with 1 tablespoon. It was just too sour for me. So I don't know how people can do it. But apple cider vinegar, 1 to 2 tablespoons at least in water before meals, can decrease your sugar by 20 points after the meal. Aloe vera, again, the dose ranges in the study from 600 milligram to 30,000 milligram, which is a very high dose. Berberine has probably one of the very good data. It's a capsule, 500 milligram twice daily, and it works exactly like metformin, and it improves the sugar by 25 to 30 points. Karela, you have to have 100 milligram of cooked karela every day or a 50 to 100 ml of juice. And I tried this too. I brought karela powder just to see, what happens. Obviously, it was way too bitter for me and I could not drink at all. So you get the point. You have to drink or eat a lot of them on a daily basis. And you can see on the right side, the blood sugar improvement is somewhere between 8 to 12 points, so 10 to 12 pounds, with some exception of 25 points. What that means is your A1C will decrease by 0.5 to 1 at the most. So yes, if you have a 6 and you go to 5.5, great. If you have a 6.5 and you go to 6, great. But if you have an A1C of 9, 8, you're not going to get away with just plants and herbs, and you will need medications. So while I have no problems using these, I think they're beneficial for early stages of diabetes. And if you have bad diabetes, please do not start the medicine. Please do not stop the medicine and just go on herbs. You can use them together, but please, please, please do not stop medications. Okay. So now let's talk about the newer drugs, because I think a lot of questions come to me on that. How do you treat diabetes or pre-diabetes with newer drugs? So let's go over all the drugs which are available, and I'm going to focus on the new ones. So glucophage or metformin is a time-tested drug for last 30 to 40 years. that decreases glucose formation from the liver, causes weight loss, and improves insulin resistance. Then you have glitazones like Actos that tells the body to use your own insulin properly. And the glitazones increases your glucose absorption in the muscle. And that is why I was pointing out before, the more the muscle, the better you are. But for the glitazones, the problem is it causes weight gain. And then there is sulfonylureas, which are the time-tested oldest possible drug, like the glipizide, the Amaryl, the glucotrol, the glyburide. These were the first drugs that were approved by FDA many, many years ago again, and they increase the insulin from the pancreas. So they will cause weight gain, but they also are a great drug to improve diabetes because they're cheap, and people who cannot afford other newer medication, these are wonderful drugs. Let's focus more on the new drugs though. So the biggest class is GLP-1. GLP-1 has many drugs now. It's Mounjaro and Zepbound. Mounjaro is used for diabetes. Zepbound is used for just obesity and no diabetes. Then you have Wegovy that is used for obesity. Ozempic on the same compound but used for diabetes. And then Rybelsus is the oral form of these GLP-1 because all the others are injectable and they have to be taken as an injection. So what do? They decrease blood sugar after you eat food, and they're approved both for diabetes and non-diabetes. Then you have the Januvia, the Tradjenta, and Onglyza. They also decrease sugar after eating, but they're weight neutral. And I'm going to show you a slide about how they act. And then we have the Invokana, Jardiance, and Farxiga. This is again a new class of drugs, and that works on kidney to improve blood sugar, and they also cause weight loss. And then finally, we have insulin. Okay, so this is a slide, may not show very well, but this actually tells you where do all the drugs work. So one component of diabetes is decreased insulin. So your pancreas also fails and it doesn't make enough insulin along with the insulin resistance. And that's a component both in type 1 and type 2. So glipizide type of drug work on the pancreas and they increase the insulin. And then metformin, like I told you, it increases the production. Normally there's an increased liver glucose production in diabetes, and that is shut down by the metformin. Same thing with muscle. There is decreased glucose uptake, which is shut down by Actos, and that's where Actos work. And then, of course, the kidney. Kidney can actually reabsorb glucose. One of the reasons why we don't really go to the bathroom after eating meals is because when the glucose goes in the kidney, almost 90% of them is absorbed back. Otherwise, we'll literally be going to the bathroom every 5 minutes. So increased glucose reabsorption happens in diabetes, and SGLT2 inhibitors, the Invokana and the Farxiga type of drugs, stop that. And then finally, in the stomach, there's a compound made called as incretin. And incretin actually increases the insulin production from the pancreas after we eat food and is one of the major contributor to diabetes if you don't have enough incretin. And in diabetes and prediabetes, we start to get less incretin. So where do GLP-1 agonist and DPP-4 work? DPP-4 is your Januvia, and the GLP-1 is the other drugs like I just talked to you about. They increase the incretin and increase the insulin production from the pancreas. And along with that, they actually decrease the stomach emptying so you don't eat as much. And that's how you improve diabetes. So let's talk about the SGLT2 inhibitor. And this is your Invokana, Farxiga, and Jardiance. Very commonly used nowadays. They are a great drug to improve heart disease. Their safety data now goes up to 10 years. And overall decrease A1C between 0.7 to 1.2, but some of the studies are showing the A1C improvement as 1.5 to 2% as well. And they're one of the great drugs to cause weight loss again. The problem is because they're working on the kidney, you're putting out a lot of glucose in the urine. So some people can get UTI and yeast infection, which happens in 10% of cases. But usually it's one time, and after that you don't get it again. Very few people will get a second yeast infection. And then you dizziness and hypotension or low blood pressure in the elderly, because again, they're increasing glucose in the kidneys, and the water goes along with the glucose. So they're great for patients with kidney disease, and they actually improve kidney function, but you must drink lots of water if you're taking these drugs. So the next class I'm going to talk about is GLP-1 agonist. Their daily use, which are Byetta or Victoza, we don't even use them anymore. And then their weekly, which are Ozempic and Wegovy, Trulicity, which is just for diabetes, and then Mounjaro and Zepbound, as I talked before. So what are the GLP-1 effects? The biggest effect is, of course, on blood sugar control. It helps the pancreas release more insulin when needed, which lowers the blood sugar levels. But the biggest impact of GLP-1 has been on weight loss. So the users can experience significant weight reduction, often up to 20% within 6 to 12 months, and up to 30% weight loss has been seen because you feel fuller sooner and you feel fuller for long duration, so you don't feel like eating. And I think the major game changer has been the effect of GLP-1 on heart health. So studies have shown that these medications reduce the risk of heart attacks, stroke, and death due to cardiovascular disease in high-risk patients. And finally, the food noise reduction. Many users report a reduction in constant thoughts about food and hunger pangs. So it actually manipulates your brain so you don't eat as much. Heart disease data, and I can tell you there are now 20 papers out there on GLP-1 and heart disease. There is 50% lower risk of heart failure. This is directly from Cleveland Clinic. 12% reduced risk of heart attack, 37% reduced risk of heart arrest, cardiac arrest, and a 41% reduced risk of dying from all causes. So they overall improved your dying if you use these drugs. Even more effects are now coming on GLP-1. There's definitely a decreased risk of kidney disease, especially in diabetics. There is decreased risk of fatty liver. And guess what? The fatty liver is up to 50% in our South Asian population, called as NASH. There's promising early data, not a lot of clinical trials, but there's promising data that they may improve Alzheimer's disease. And there's also improved data on mobility and joint pain. I think that is directly related to the weight loss. The more weight you lose, the less arthritis, the less joint pain, and then improved sleep apnea, which again is directly related to the fat. So once you lose weight, you also lose visceral fat. And when you lose visceral fat, you improve diabetes and you improve heart attacks. What are the side effects? Of course, when you take it, because they're making your stomach fuller, nausea, vomiting, and then headache, because sometimes diabetics can get low blood sugar with these medications. So you may have to cut down some of the other medicines you are taking for diabetes. It cannot be used if you had severe pancreatitis or if you have a family history of pancreatic cancer. You absolutely cannot use these drugs. And there is a small increased risk of thyroid cancer. So if you have thyroid nodules, please get them evaluated by your doctor before you stay on these drugs long term. And then one of the biggest data which is now coming out is that if you do not eat protein with these drugs, you will lose muscle mass as well. So the goal is to start slowly, increase your protein intake, and then you will have less fat, less muscle loss, and more weight loss. And one of the caveat for these drugs, which you have to think about, is that once you stop the drug, the glucose will go up and your weight will go up. So you have to be very careful for what you do. Okay, I think if there are any type 1 diabetics or type 2 diabetics, I do want to talk a little bit about the insulins. We have great progress made and research in the insulins to manage diabetes. So Lantus and Tresiba, all your long-acting insulin, which lasts for 24 hours. But then we have Novolog, Humalog, Apidra, and Fiasp. They're quick-acting insulin, and they can work within 15 minutes. You now have pens. So pens can calculate your insulin according to your carbs. They're smart pens. So you just put in your carbs and the pen will actually tell you how much insulin to take. So amazing discovery. And then of course, a full lecture I can do is on insulin pumps. They have so many types of insulin pumps, and they've become very sophisticated. Now we have wire-free insulin pump where you can't even see it. And these have now starting to talk with the CGM, continuous glucose monitor. So you wear the continuous glucose monitor, you wear the pump, the glucose monitor tells you what your glucose is. And the plan is to make it completely build an artificial pancreas where automatically the CGM tells the pump how much insulin to give. So we have come a very long way in diabetes technology improvement. And I'm actually not going to go into more genetics and the islet cell transplant because I don't think that's the focus of today's talk. But I'll be happy to take that in questions. So, my last point is key things to remember for diabetes. Get tested for diabetes. No matter how young you are, you're never too young. Change lifestyle today to prevent, as prevention is better than cure. And once again, I didn't talk about exercise and meditation because, again, these are different topics and we have covered them otherwise. Maintain your BMI to less than 23 if possible. And remember the ABC of diabetes. A1C less than 7, less than 6.5, blood pressure 135 over 85 or even less, cholesterol LDL less than 70, triglycerides less than 150. And of course, we are not alone in this journey. We have a lot of new drugs which are available which will help control our diabetes. And before I stop for questions, I do want to answer. I think I had put in a slide for Lipitor, but somehow it didn't make it. So there were 3 or 4 questions on the statins and diabetes. And yes, clearly statins do increase the risk of diabetes. The higher the dose, the higher the risk. The Crestor and Lipitor, atorvastatin or rosuvastatin, are the highest when it comes to diabetes development. So if you're on the highest dose of rosuvastatin or atorvastatin, like 40 or 80 milligram of Lipitor and 20 to 40 milligram of Crestor, you have a 25 to 30% chance of becoming a pre-diabetic and developing diabetes if you are a pre-diabetic. However, even in 2025 guidelines from the American College of Cardiology says that if you have any risk for heart disease and you're trying to lower that LDL to less than 100 or less than 70, you should not be stopping the statins and manage the prediabetes by other means. If you have to switch, pitavastatin and pravastatin have the lowest risk of, and I'll put that in the chat as well, pitavastatin and the pravastatin have the lowest risk of developing prediabetes. So that is your answer on statins and prediabetes and diabetes. So you can switch. Unfortunately, the most effective are the Lipitor and the Crestor. So you may have to pay the price with the LDL, but there's no harm in trying to switch and see what happens to your LDL. The second question, which had come in the same regard, was can HDL be raised by other things than exercise? And do Januvia, like sitagliptin, have an effect on the HDL? So yes, sitagliptin and Januvia in half of the studies have shown that it increases the HDL between 5 to 10%, which could be significant in somebody who has a very low HDL. But then another half of the study showed that there was no improvement in the HDL. So unfortunately, the drugs which we use for HDL, one of the drugs which really raises HDL is niacin. But niacin has been associated in long term with increased risk of glucose or higher sugar. So you pay the price. But niacin has been used in good amounts. Even fenofibrate, which is named gemfibrozole fenofibrate, can be used to improve the HDL as well. But the way they improve HDL is because they lower the triglycerides. So all of the other statins and fenofibrate, omega-3, they will improve HDL slightly, but nothing improve HDL like 20, 30, 40%. So I hope that answered the question on HDL. And I think I had already answered the question on jackfruit. And now we'll take more questions from the chat.
I can maybe, Renu, keep pointing out the questions for you. So the first question is, do physical activities like a 10-minute walk...
You can unmute yourself so people can hear the question.
Do physical activities like a 10-minute walk or doing 20 to 30 squats help in minimizing post-meal glucose?
Yes. So exercise clearly has data, especially if you do 10 to 15. The question was, does exercise minimize postprandial spikes? And it clearly does. If you start to walk after 10 to 15 minutes, so the food had time to go into your stomach and get digestion started, um, 20 to 30 minutes or squatting will reduce your postprandial spikes. There's data on that.
Can we take berberine tablets every day with GLP drugs?
You can take the berberine tablets with the GLP-1 drugs. Unfortunately, if your nausea goes up, then you have no choice. So you just have to measure the side effects versus the effect of the medication.
Do we have to take GLP drugs for life? Repeat the question. You can
So
just repeat the
one
question.
second. Okay, so the question was, the third question was, can we take GLP-1 for life? So I don't think I will answer that question because I don't think we have the data. The data is now out for 10 years. So we have good data on GLP-1 for 10 years and the safety is phenomenal. In fact, there were some case reports that came out on that it causes retinopathy or worsening eye disease or macular degeneration. And the current studies do not prove that. The retinopathy or the diabetic retinopathy can get worse in people because you're improving the glucose. And that happens with any medication. When you try to get your A1C down from 9 to 7, your retinopathy will transiently get worse and then get better. And the macular degeneration, there's actually data that it may even prevent macular degeneration. So there's no data on eye disease, which was one of the problems we were really seeing. The micronutrients will go down because if you lose 30, 40, 50 pounds, you will develop deficiency of vitamin B12, vitamin D, vitamin A, vitamin B6, and other zinc, magnesium, other micronutrients. So it is important that you don't lose that weight very quickly. And that's why slow and steady wins the race. But the data I can say is out only for 10 years. We do not have data lifelong.
What are some healthy food substitutes to help sugar craving?
So anytime when the question is what are the healthy substitutes to improve sugar craving? So the biggest thing I can tell you is protein, 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 fiber, fiber, fiber. So if you add protein and fiber to your diet, you will satisfy your health craving. Remember, the more carb you eat, the more insulin it produces from the pancreas, the more insulin is a growth factor, so it stimulates your hunger, appetite, and it stimulates growth. So it causes weight gain. And then weight gain causes more insulin resistance. You make more insulin. So the more carbs you will eat, the more hungry you will become. And in fact, even when we ask people to treat hypoglycemia or low blood sugar, we tell them to only have 4 ounces of juice, but immediately followed with peanut butter sandwich or a milk with graham crackers. So it has protein and it has fiber. So anytime you add protein to your diet, a simple thing is when you're eating something with potatoes, add some tofu to it. So that'll get you protein. Or switch the white rice, add some quinoa or brown rice to it. That'll add fiber and protein. Or like me, keep adding salads every meal. And there's clear data to document that if you eat salads before the carb food, your postprandial spikes actually improve.
Is the combination of Ozempic and metformin safe for an elderly person close to 80 years old?
So the question is the combination of Ozempic and metformin safe for a person who is 80 years old? So something I would say about metformin. So even though metformin has clear data that it can be used even with a creatinine clearance of 33, which means your kidneys can be pretty bad and you can still use metformin in up to 1500 milligram of dose. Having said that, the creatinine does start to rise as you get a little older and your GFR starts to fall. So as the GFR falls, you will have more side effects because both Ozempic and metformin will cause nausea and sometimes abdominal pain and diarrhea and constipation. So if you can tolerate and your GFR is good, there's absolutely no reason to stop one or the other. If your GFR is decreasing, actually Trulicity has even better data that can be used. Most of the GLP-1s now can be used till the GFR of 30. which is pretty low.
This next one, Renu, is what about this comes from a physician, I believe, but how about anti-gravity exercise in lowering sugar levels? And so you might want to so if you could repeat the question.
So the question came from the physician that do anti-gravity exercises improves sugar levels? And there is some data to suggest, yes, that they can. So if you cannot do a lot of walking, running, and other exercises, and if you do anti-gravity exercises, yes, they will improve your sugar levels.
You can have, okay. So this one is just let's use this in general. Cholesterol 270, but zero calcium score and very low lipoprotein little a of 10. Should you go on a statin? We don't know the LDL, but that's the total.
So the question came that my total cholesterol is 270, but my LP little a is 10 and my CAC score is 0. So one of the things I do want to point out to our listeners, and we have now seen that many times, that remember, the calcium score is only going to identify the plaques that are calcified. So what happens in plaque formation is first you have a deposit of cholesterol and inflammation that forms a plaque, and then eventually that plaque gets calcified. So there is a good possibility that you have a CAC score of 0, but you may still have a plaque in your arteries and you may not be able to find. Maybe 5 years later, you might be, because that plaque is then calcified. So a cholesterol of 270, and I'm pretty sure that is directly LDL. If your LDL is high, this is the time you can protect your heart from not getting a cardiac event. So definitely you should go on statin. Remember, LP little a is a genetic marker, but only 25% of South Asians have high LP little a. So not every South Asian has high LP little a. If your LP little a is high, that's just an extra risk factor for you to get heart disease. So just the fact that you don't have LP little a or you have a normal CAC score, I would not forget this cholesterol of 270.
Now this you will address in your reel, I know, Renu, but you might want to repeat the question. Is honey better than sugar?
Actually, the question came in, is honey better than sugar? So I'm actually just made a reel on it and we'll be releasing it in the next week or so. But absolutely no. So honey has actually more carbs than sugar. Sugar has 4 grams of carb in 1 teaspoon, and honey has 6 grams of carb that I showed you. Honey also has more calories than sugar, 63 versus 45. So there is some earlier studies in 2004 which showed the honey has lower glycemic index. And I know we didn't talk about glycemic index, so there's a lot of concept about low glycemic index of food and high glycemic index. So there are some food, like if you eat a full fruit, it'll have a low glycemic index, but if you have fruit juice, it'll have a high glycemic index. High glycemic index means how quickly it is raising your sugar. So honey had a lower glycemic index in the earlier studies in 2004 and 2005, and it also improved some, it had some antioxidant properties, so people thought it was good. But a more recent study in 2021, they analyzed 7,000 patients and compared them with honey versus sugar, and they did not find any improvement in metabolic parameters or lipid panel even. And in fact, if they said because people were using honey more than the sugar because they think it is safe, they actually had worsening glucose levels and diabetes. So that's my take on honey versus sugar.
Can BEMDAC be a substitute to statin, which is bempedoic acid? So
question was, is bempedoic acid a substitute to statin? I think from my studies, what I have read, it is an additional drug which is used along with statin when you do not have control of LDL and you cannot maintain an LDL of less than 70 or 55 if you have cardiac disease. Bempedoic acid is a great drug which is used as an addition, and that's where I use it. However, if you absolutely cannot take statin due to severe side effects, muscle aches and injury, and you can't do it, then of course, any other drug can be tried, like the Zetia, bempedoic acid, even fenofibrate.
Uh, can you eat as much fruit of all kinds all day for good health?
A great question came. Can you eat as much fruit of all kinds every single day? So I think in my our Indian diet talk, we do have the carb content of every fruit, and if not, I'll be happy to post it. What you need to do is again think about carbohydrate as a daily. So if you're going to eat 1.5 carb as a snack, like I told you with 1500 calories, you can eat up to 22 carb. And you can take that as half a pear. You can take that as one full orange. You can take that as 1.5 cup of watermelon. You can take 1.5 cup of berries because they have very little carbs, but you may just have one slice of mango and get 22 grams of carb. So it all depends upon how many carbs the fruit has. I never tell people, oh, give this up completely, because the more you give up, the more craving you have. But remember that you may have to eat less of some fruit and more of the other. Now, I would not say that you eat 7 fruits a day. Usually 1 to 2 serving of fruit and 2 to 4 servings of vegetable is important on a daily basis.
So this is a long-winded question, but I'll summarize. So currently taking a statin, 10 milligrams of atorvastatin, and cholesterol is in perfect control, but does not mention LDL. Recent A1C is 6, calcium score 59, CT angio showed LAD has mild to moderate plaque. Trying hard to keep A1C to bring it down, 5 hours tennis, 8 hours of walk every week, sleeping well, trying to follow plate method. What else can I do? Remember, LDL is not stable.
No. So the question came in that a person who has a positive CAC score, a positive CT angio with an LAD lesion, and he's taking a 10 milligram of low dose Lipitor to get his cholesterol under good range.
And LDL is less than 60.
LDL is less than 60, which is great, which is where it should be anyway, and now has an A1C of 6. And I can tell you that is the story of my life. I now have an A1C of 6 with taking 80 milligrams of Lipitor because I have heart disease. So the question is, if it doesn't do with diet and exercise, what should you do? So if you want to keep your A1C less than 5.7, I think this is where I would believe that you can take some of the plant supplementation. You can try those. Berberine has good data, so maybe try that. Or a low dose metformin, just one tablet, 500 may get you where you need to.
Okay, so we are avoiding questions on goiters and non-diabetes. You can make a mention.
So there's a questions coming in on goiter and non-diabetes, and maybe we can do a podcast on thyroid at some point because a lot of people have thyroid disease, and we can also intertwine it as to how it affects the heart health. And maybe we'll take questions on those separately, and I can answer those questions later on personally.
Should I stay on Ozempic if I have 6.1 A1C, rosuvastatin 10 milligrams, losartan 25 milligrams for BP? Do I need to stay on diabetes meds like Ozempic to manage diabetes, or do I need to reduce my A1C further to 5.7? We don't know the age.
Okay, so the question came in, my A1C is 6.1 on Ozempic. Should I try to lower it further and continue Ozempic, or should I stop it, or should I do something different? So again, depending upon the age, if you are in your 30s and 40s, I would like to keep your A1C as low as possible. So if you can get it down to 5.7, even better. But if you're 75 years of age, then 6 is very good for you. Then you don't need to worry about improving it further. So I think, like I told you, the goals are very different as we get older. But I would say that anybody at least in today's day and age, if you can maintain your A1C as close to normal as possible, you will actually save yourself from being a diabetic and complications, and you will save yourself the problem of heart disease. And one of the things which I didn't mention is the macrovascular disease, or the clock for heart attack or clock of heart disease starts to tick at pre-diabetes and not diabetes. So the heart disease stroke type of things start to much earlier than you become a diabetic. So I think if you can keep it lower and you're young, you should try to.
We're at 11:28, so we'll take one or two more maybe. Can berberine be taken in addition to metformin, or if metformin should not be taken if berberine is being taken?
So it all depends upon, question came in, should berberine be taken with metformin? And
Okay.
can it be taken with with metformin? I think the side effect profile may increase, but you can try to take it together. And if you take berberine and your A1C improves, eventually you can stop the metformin.
I think we are pretty much done, Renu, so you can thank.
So I think we are at 11:28, and we have pretty much answered all the questions. If anyone has more questions, please, we'll keep the WhatsApp group open at least till Monday. So keep writing more questions and we can keep answering them. And if you have any topics for discussion in the future, which you would like us to address, we would love to do those. Just keep those questions coming, keep the group going. We learn from you, and hopefully we'll continue to educate.